We've got a very special presentation tonight. We're going to be talking about COVID-19. We've got Dave Talan with us. Obviously, there's lots of questions that people have. And just a few points before we get much further. There's a lot of people on the stream. The tech's looking pretty good. But if for some reason it sort of crashes on you, come back in about 5 minutes, go over Shardy, go over Wee, and we'll reboot the system and start the stream again. Second of all, we have got a... Well, first, before that even, a disclaimer. You know, this situation is changing very rapidly. Knowledge is changing very rapidly. Even in the last few hours, I've been sent some new articles that are pre-press about some of this stuff. So even when you watch this tonight, or if you watch the recorded version of this in the next few hours or days, make sure that you're always continuously going back to the CDC, WHO, and local health experts, because it does change constantly. We're not going to be talking too much about how many cases and stuff there are. We're going to be talking about from an ER perspective, what you can do to protect your patients, what you can do to protect yourself. We went live just a couple of hours ago with our own chapter in Compendium. So many people, hundreds of people have been asking us to put this into Compendium. So we got that up. We wrote it internally. We've had it reviewed by a number of ID experts, and we will update that to any new significantly important clinical information over sort of at least once a week and more frequently than that if we need to. Again, most of the changes that you're seeing right now, most of the stuff you're seeing on TV is about how many new cases there are. We'll talk a little bit about that, but that's less important to us in the clinical areas right now. So let me give you a quick background, and then I'm going to get Dave Talan, professor from UCLA, and we're going to have a little discussion here. So SARS-CoV-2 is the virus, and corona or COVID-19 is the clinical syndrome, just for the nomenclature, which is sort of the accepted nomenclature right now. We know that these coronaviruses are really common. They cause the common cold about 20% of the time. They're found in humans, in camels, in bats, in cattle. And the thing we think's happened here in Wuhan, China, where you've got these big markets where you've got bats and civets and all of these different animals together, and they're getting slaughtered together and lots of viruses transmitted. This is probably where this virus came from and now has infected human beings. Obviously, the spectrum of this disease appears to be from essentially no symptoms, predominantly in kids, up to frank respiratory failure and death, particularly in the elderly. Big spikes in mortality over the age of 70 and over the age of 80, and people with underlying lung disease, although this is much more mortal than standard flu, so we are going to see younger people that will die of this disease. Incubation period could be up to about 14 days, and the infectivity could be up to about 14 days. Dave's going to talk to us about that. These are sort of CDC numbers. They are trying to be very conservative so that if you want to quarantine people before and after a possible event, that you make sure you don't send them back into the world before they've finished. Just in terms of some of the mortality, actually Dave showed a table like this a couple of weeks ago at UCLA. So for MERS, the mortality was about 34%. For SARS, the first SARS, about 10 years ago, about 10%. Seasonal flu, somewhere around 0.1%. It obviously changes between the flu season. Right now, the mortality for COVID-19 appears to be 2 to 4%, but that is probably significantly overstated because we haven't done a lot of testing yet, particularly in the US. So I expect that number will come down, but it'll probably, the experts are telling us, stay significantly higher than the 0.1%. I heard a gentleman today, an ID doc from Johns Hopkins, saying he thinks it's going to be less than 1%, but still probably 5 to 10 times greater than flu, which is still a big deal. So in terms of trends in the upcoming months, again, the experts are saying, we don't really know, they think that about half the US will probably become infected, that the mortality will be somewhere around 1%. That means that potentially 1 million people in the US will die, and probably around the same in most other countries. Compare that to a really bad flu season like we had last year with about 80,000 deaths. And a lot of the public health stuff we're going to do, or you're seeing, is to try and flatten this curve. So let me now bring in Dave Talan to speak specifically about what flattening the curve is, and then we're going to go into much more detail. So Dave Talan is triple boarded in emergency medicine, infectious disease, and internal medicine. He was the chair at Olive UCLA, and now is back at UCLA working clinically and also still doing ID work. So thanks for doing this, Dave. I know this was really last minute. But a lot of people are really interested in this stuff, as you are aware. So can you first of all tell us about what this idea of flattening the curve is? We hear them closing schools and closing airports and reducing travel, and even by the time we finish this presentation tonight, we might be hearing of significant travel restrictions from Europe. What does flattening the curve mean?
Flattening the curve means drawing out the epidemic. I think, okay, spoiler alert, everybody, this is a pandemic. Finally, the WHO acknowledged that, and that was something we knew because there's disease virtually in every continent except maybe, I'm looking at the Johns Hopkins map, Mel, and the only place I don't see a red dot is Greenland. We should look into buying that. I wonder if anyone's thought of that. Anyhow, so the idea is you would like to not see this pandemic accelerate quickly and lead to the maximal number of infected people, cases, deaths, severe illness in a short amount of time, because that's going to overwhelm our hospital system, our ability to surge. We like to flatten out the curve so that we have more time to build up the infrastructure to deal with this, to have the seasonal influenza epidemic die off. We're already seeing influenza cases come down. It would be nice if we didn't have an epidemic of influenza at the same time we have a big spike in coronavirus cases. And then the longer we can draw out this epidemic curve, the more time we have to develop vaccines, drugs, learn how to protect ourselves in the community, protect the most vulnerable individuals such as the elderly in nursing homes. So that is the strategy right now. It's no longer containment, which is I think what some people are still trying to do, and closing down travel and airports and things like that. It's more mitigation.
Right, so that's an important concept that I think a lot of people need to get their head around, because a lot of the ER docs have noted, and even in the chat room I can see here people saying, like, if 1% mortality, we're talking, 1 million people, that's a lot of people in ICUs. We can't handle that volume. So that's exactly what this is about. Of course, we can't handle that if it happens over a 2-month period, but maybe if we can spread this over 6 months, over 9 months, you've got a bit better chance of not having sort of people basically die in the door of the hospital versus inside the hospital. So let's talk a little bit about testing then. The test that's currently CDC WHO approved is a PCR test. And I got a really good question yesterday. We've actually put it in the textbook. Trying to find what the sensitivity and specificity of that test is almost impossible. It looks like, from what I can find, about 75% sensitive. PCR tests are usually pretty specific if they're not contaminated, but do you have any information on that for us?
I think, Mel, this is coming from a certain orifice, because, when we talk about performance characteristics of tests, the first question you have to ask is, what's the gold standard? What's the reference standard? And there's not a perfect reference standard for PCR. We do know that if you isolate unique and conserved regions of viruses, those types of molecules, that these tests with laboratories that have a lot of experience and do them carefully have a very high accuracy. But then the question is, well, what are you comparing it against? Well, you can compare it against viral culture, and that helps for positive tests. But we know that PCR detects molecules long after the virus can no longer survive, so they're not exactly equal. You can have negative controls, so people who have no symptoms, no exposure to the disease. You can have controls that have illness, but illness due to documented other viral infections. Those can be controls. And then you can also compare against not only clinical illness, but eventually we will have antibody tests. So there's all sorts of ways to try to get at how accurate a PCR test is. But right now we're sort of relying on the fact that if these tests are developed the way we usually develop PCR tests, they tend to be extremely accurate. And in the meantime, the type of performance testing that I talked about is going on. But I don't think anyone can tell you exactly what the sensitivity and specificity is. And then if you want to make this really boring and drawn out, it depends on how you use the test. So if you screen a large population of asymptomatic people to see if there's any asymptomatic COVID disease or transmission out there, you're going to exaggerate the number of false positive tests, even if a test is nearly perfect. And the opposite if you have a population that almost always has the disease. So the short answer is, I think it's believed that these tests are highly accurate. But it's early in the game, and we don't have some of the background testing that would make us feel more sure of that.
If we just go to this slide for a second, I know a lot of people have been very frustrated by the US response. This is a quick slide that shows how many tests per million people or 1,000 people, per million
Right.
people. So South Korea has been testing nearly 4,000 people per million of population, the US 5. This is changing very dramatically. We haven't had the test here. I think in California, they've only done a few hundred. That should change quickly, as it appears that we are about to get a giant shipment from somewhere of millions of tests. I know in the chat room, a lot of people are frustrated because they either can't get the test or they're told when they ask for the test that they're not allowed to get it, or the health department sort of cuts it off. So the test is not perfect, and we can't get it right now. So there's a lot of frustrated people out there. So let's go further forward here. And there's just one article I want to show here that says exactly what you said. If you then do the test, and this was one study in China that looked like it did it at a pretty low prevalence population, they thought that they were having huge false positive rates. So right now we have a whole bunch of people that want to come and get tested, but we don't know the test characteristics, and that's not the right thing to do. So what do you say to people? I'm at home, I'm febrile, I think I might have this disease. Should I write it out? Should I come to the emergency department? Should I get tested if there were tests? Or should I just stay the hell home and only come into the hospital if I'm really sick?
Yeah, well, I think we test for three general reasons. So the first reason we test, especially from our perspective as healthcare workers, is we test to protect. We test to know if somebody's infectious to us, and we are very important. It's not that we're more valuable in the human race, but at a time when there's health problems, you have to protect healthcare workers. So we test to protect them. We test to protect the vulnerable who are in the healthcare space, such as elderly and people with comorbidities and all hospitalized people. So that's one reason we test. We test to do surveillance. Now, this could be done in a much more organized fashion, but the political sort of solution has been to now release these tests and encourage doctor judgment as to when to use that. That means that a lot of people are going to get tested, people for whom the result isn't really going to affect what we tell them to do very much, right? So, but that will be our surveillance. It'll be wherever these tests can be done by whatever doctor decides whatever patient can get it. It will no longer be restricted to the definition of PUI. So we will get more information on surveillance. That is how prevalent this disease is. It won't be as systematic as you might be able to do it scientifically, but it'll probably get us close to the answer. That type of information on surveillance informs public health authorities to make really, really difficult decisions on how to limit or increase social distance. Should we close schools? Should we mandate, like in Italy, that businesses close? Things like this. These are really, really important decisions that have adverse consequences in both directions. So if you impose social distancing restrictions, closing schools and things like that, and it's not necessary, then that wreaks havoc on the economy. It's particularly hard on the poor and parents who have difficulty making sure that they can take care of their kids and support their households. On the other hand, if you institute mandatory separation and social controls and school closures too late, then it doesn't work. So surveillance is really important to make those types of decisions. And then the last reason I think that we treat, Mel, is to decide on treatment. We debate this with like Tamiflu treatment and testing for influenza. Right now, there isn't a treatment that we know is effective against COVID-19 disease, but there's some really promising candidates, and once that's the case, then that will be another reason to test. To your question, what do you do with the average person? I think if they want to test, the idea is to give it to them. We just don't want people to flood the emergency department who have respiratory disease, who aren't sick and don't really need our care, and going to expose the most vulnerable who also need care in the emergency department. So if there is testing, it should be decentralized away from the hospital, out in the community, and also best outside of doctors' offices and waiting rooms.
Yeah, there's an interesting thing that's occurring in England and other places around the world. I think it's starting to occur here, which is called drive-through testing. Basically, you drive up, decentralized place, away from the nursing home, away from the hospital, and you get the test done in your car. The first screening is actually done by things like Skype, where you call in, you talk to the doctor remotely or the nurse, and then they go, okay, this person should get a test. Then you go over and test them in their car, they drive home. So that kind of decentralized testing makes sense for large populations. So again, this is for healthcare workers. I'm sure there's a lot of non-healthcare workers there, but the idea of not coming to the hospital when you're feeling a bit sick is a little bit strange, but there's not much we can do unless you're really sick. So if you're just a little sick, stay home is what we're trying to tell people to do.
Right. I mean, coronavirus increases the ante. I mean, we don't know what the case fatality rate is going to settle out as, and we're worried that it's much more than seasonal influenza. But guess what? It's not good to pass on your flu either, if that's what you got. So if you don't feel good, stay home, stay away from people. I guess if you're really curious, you can find out if you have COVID-19, but very soon it's not going to matter because this is going to be everywhere.
So a specific question about that before I go into CT scanning, which is another thing that people have been screening with theoretically. If I get this, if tomorrow the air duct goes to work, gets coughed on, gets febrile, gets the disorder, then gets better, is it protected? Is she protected? Can they then go back to work a couple of weeks later knowing that they're not going to get it again? Is there any evidence that you can get this thing twice? Is it mutating fast enough that you could get it again? There was one report from China that maybe one woman had it twice. What do you think?
I'm not sure that I know. I do know that there's some evidence that if you get the usual coronaviruses, that there is protective immunity specific to those strains. One of the theories as to why we're not seeing much disease in children is it's felt that there may be some cross immunity from past infections to the usual coronavirus that protects children against COVID-19. So that's interesting. I'm not aware that recurrent infection after having one infection is clear, maybe that one case. So I don't think we know. I think we can expect that there will be people who had COVID-19 infection who are also co-infected with influenza, because every study before this, looking at respiratory viral infections, during the winter season, has found if you use PCR testing, that it's not that uncommon for people to have evidence of two viral respiratory tract infections at the same time.
Yeah, that's an interesting thing, and it's been controversial. One of the ID people I talked to said, if you come in, it looks like a viral syndrome, looks like influenza/COVID, do the influenza test. If that's positive, that will significantly reduce your chance you have co-infection with COVID-19. But you're saying that may not necessarily be true?
I don't know. It's probably true. Statistically, I think if you have one documented identification of a respiratory viral infection, that makes the chance that you also have COVID-19 much, much less, but not zero, right, is my point. And that gets to some of the things that become perhaps more interesting in our own testing that we use in the emergency department. There are rapid PCR-based multiplex panels against all the common respiratory viral infections, and we haven't used those because they are an increased cost, and although many places that run stat, that also adds bedtime to our patients, but greater use of this test might allow us to improve sort of the dispositions and what we can advise patients.
Well, let me move on for a second. I want to try and get through this and then get back to the people who are chatting and their questions. One thing that I wanted to talk about was CT versus PCR. There is a couple of small studies out of China saying that CT scanning is this great screening tool, that it can even be positive when the person is initially negative on testing and then it becomes positive later. And I would just have a word of caution to people that are reading that literature thinking, well, instead of doing a test, I'll scan everybody. First of all, that's going to be ridiculously expensive. You're not going to be able to scan millions of people, so that makes no sense at all. So I think this is taken out of the context in which these were probably sick people that were in the hospitals that were admitted. And yes, if you are sick and in the ICU, the CT scan might have some very specific findings for COVID-19, but it's not a screening test in the way we're talking about screening. So please do not take home the message, I'm going to start scanning people instead of doing these tests. So now let's talk about triage, Dave. So let's say, despite what you've said and lots of people have said, you have hundreds of thousands of people coming to the emergency department with low-grade viral illness. What is happening at UCLA? What's happening at all of you in terms of triage? Give some people some color as to what's happening. Is there a nurse standing in the parking lot and triaging people? What are you doing?
Right. That is what we're doing at both places there. And I think you've seen this, I'm sure many of you in your own hospitals. There's a sign out there, or there's a place set up that catches people on their way before they come into the hospital or get into the standard emergency department waiting room. It says, hey, if you've got respiratory symptoms, stop right here. And then either somebody comes out and meets them and triages them, or there's a tent set up. We're lucky enough in Southern California to have really good weather, and guess where the air exchanges are best? Outside under a tent. Well, in that nice weather. So that's what people are doing. They're, again, coming up with some system to separate those people who may be infectious from the vulnerable people who typically habitate the emergency department waiting room.
And that's also good, as you say, outside. My understanding of these viruses, they're covered in a little lipid layer. They're not, it's not like some other viruses which are really hardy, that sunlight and warmth and stuff can kill this. So we're hoping that this will be seasonal. But the idea of triage outside before they get in is what most people are doing. And then after that, internal triage will then occur after that. And unfortunately, like you say, it's easy for us to say in California, but if it's 25 degrees below outside and snowing, that's a little harder.
Right. Now, you asked a little bit about the precautions at triage.
Yeah.
If you're putting nurses out there to do this sort of screening, and we all will soon have a line of people with respiratory symptoms, the guidance or the best evidence supports that triage nurse get in full PPE.
Mm-hmm.
That makes some sense, right? Because right now those patients aren't screened. Some of them will have the disease. It's a high risk type of practice. So that person who is closest and doing the screening, should have an N95 mask, a face guard, the whole 9 yards.
Right. So that protection, let's go over it right now, because this is respiratory aerosolized. N95 mask, good seal, no mustache, no beard, that kind of thing. There's some funny pictures from the CDC. I'll show you a little bit later about that. Eye protection, because this can get through your mucous membranes of your eyes. And then, gown, glove, mask, the whole thing. What we found in the Ebola virus and the simulation of Ebola virus is the time you get infected when you're wearing all that stuff is when you take it off. You've done all this and you're covered in virus, and if you don't take it off properly, then you can then infect yourself. So I suggest you go on the CDC website or check our textbook. There's links there to the process, the dance. It's a 2-person dance to take this stuff off correctly so that you reduce the probability that you're going to infect yourself from that stuff. So let's talk a little bit about intubation. Actually, here's the picture of the various mustaches and facial hair that you can and cannot have. And it's hysterical, and I love that the CDC did this. And the Zorro is good, but the Fu Manchu is bad, this kind of thing. It's very, very funny. Now, we know from some other studies that the highest risk time in the emergency department for healthcare workers, or one of the highest risk times, is during intubation. We've had a lot of questions about this. So the patient comes in, they're really sick, and you've got a tube, then what can you do to reduce that probability? So we are suggesting suggesting in the textbook chapter after speaking to many experts is put these patients in a negative pressure isolation room if you have one, if possible. That you intubate them as fast as you can with as few intubation attempts as possible, so the best person, if you can get them in there. Make sure that there's as few people as possible in the room. Put viral filters on all of the connectors as much as possible. Use a video laryngoscope so that you're not going like this, trying to see their cords and inhaling all the virus, but you're a long distance away, and use a video laryngoscope to try and put it in. And then, of course, after you've finished the procedure, you take off all the gowns and gloves in the correct manner. All of these things to try and mitigate that. We know that during SARS and MERS that a lot of the ICU staff and the emergency department staff actually became infected, and many of them died. And it's presumed in some of the epidemiologic studies it was during intubation was the highest risk time. So let's talk about vaccine status. We've been told by some people in power, the vaccine, don't worry about it, it's going to be here in 3 months. And then other people at the CDC said there's not going to be a vaccine that's deployable at volume for at least 12 months to 18 months. What do you say, Dave?
That's what I'm reading too. I'm not a vaccine scientist. I think it's reasonably easy to develop compounds that could be vaccines, but then testing them to make sure that they're safe, and ultimately in trials to demonstrate their effectiveness, that is what takes the longest amount of time. And I have also heard that whereas trials are starting very quickly, with some of these vaccines, we won't have a licensed vaccine for probably a year at best.
So this is again the idea that if we can flatten that curve, hopefully we can get a virus later on. We talked a little bit about the utility of antivirals. There is a couple of possibilities there, and even chloroquine in vitro apparently has some antiviral activity here, but we don't know if it's going to be that useful in the test tube it works. We don't know. I don't know. People might be using this in very sick patients just to try it, but it'll be a while before we have any more information on that. So now let's get to some very specific questions that are coming up, and we're going to pimp you on this. And the first one that's come up a lot just today, Italy just reported 200 cases. Their mortality seems to be very high. And so there's a lot of questions about just how mortal is this disorder? The problem with the data from China is, frankly, we don't know how much we can trust it. There's reason for them to downplay it. So although most of the evidence that we have, we're talking about on the New England Journal and other places, it might be skewed. The concern is that what we're getting from Italy might be more reasonable, in which case it's a bit more frightening that the mortality may be significantly higher. In South Korea, my understanding, the mortality wasn't very high. So I think a lot of this is about how many people you've done the test on, what's the denominator, and what the reporting is. So I think it's going to be a little bit confusing for a while as to what the exact mortality is. So I wouldn't freak out. I don't think it's Ebola, but it certainly seems to be worse than flu. Exactly where it's going to pan out, I'm not sure. Anything to say on that, Dave?
Yeah, I mean, the tendency always at the beginning is to predominantly test the sickest people who will have the worst prognosis. Where testing has been used the most in South Korea, so they have about 200,000 tests. The case fatality rate is 0.6%. And so, as you were implying, or maybe you were just saying, the more we test, then that fills out the denominator. And we know that this is a disease where it can only be a mild illness, and actually an illness that doesn't even look like a lower respiratory tract infection. It may more look like just a common cold with sore throat and runny nose. So I would tend to believe the numbers that come from the places where where they've done the most testing.
Right.
Yeah.
Another question that comes up a lot is surface fomites and how this is spread. So the best evidence right now is that it's droplet spread. It's not like measles. When you've got measles, it sort of can float in the dust particles and stay for hours and hours. This is droplet spread, seems to drop pretty fast. There is an article which I was just given 30 minutes before we got up here. It looks like it's pre-release, perhaps for the New England Journal, that suggests that this can live as a fomite on surfaces for up to 24 hours. But again, until that's published, I'm not sure. But what about usual coronavirus? If I have a normal cold and I sneeze onto my desk, How long does it live there? Hours to days or minutes?
I don't know. I think the information that you just imparted might give us a clue. But we do have some more information on when patients who have coronavirus infection, when they're infectious. And part of the reason that this infection has spread so rapidly is it's been found that high levels of viable virus get excreted very early on after the onset of clinical symptoms, when people are still feeling pretty well. And the peak viral excretion, this is live virus that can be grown on viral culture, peaks at about day 5. But you can get the virus, you can isolate the virus from the nose and throat during those first 5 days at very high levels and before people feel that sick. So they might be out and about and they may not be coughing much. They may just have a little tickle in their throat. Then it's found that the level of the virus comes down after a peak at about 5 days and is mostly gone by 10 days. So what we're learning is, yes, it's dangerous. It can spread very early on. That explains the dynamics of the pandemic. But patients themselves may be safe in terms of not being infectious after the 10th day from the onset of their symptoms.
Yeah, and so again, this is why this idea of people sort of going to your quarters and staying away from other people for a while is the best thing we can do to slow this spread. A couple of questions about one here that says, look, I'm seeing lots of people with fever and lots of people with cough. I've done no testing. It sure sounds like coronavirus to me. But that also sounds like the common cold. It also sounds like flu, and that's the difficulty we've got. One of the theories going around right now is that the vector for this is kids. Because they're not getting clinically sick, they may be running around and spreading the virus. And there hasn't been, as I know to date, a lot of testing specifically in sort of asymptomatic kids in primary schools to see how common it is there. And it's a little frustrating with all this because we're so early. We just don't know the epidemiology there, but I'm sure that will happen. One of the specific questions people had clinically was, what about if you've got an asthma patient? Should you be giving them nebulizers in the emergency department and spraying that virus everywhere? How should we deal with that?
Yeah, I'm glad you brought that up because there's a lot of things that we do that can precipitate people expelling respiratory droplets with COVID-19 virus. So BiPAP, I would really discourage use of BiPAP for a pneumonia patient in general. This is not like CHF where you can do some things and reverse the patient from their course towards needing intubation. I think if you have someone in respiratory distress instead of BiPAP, you're going to be much more quickly going to intubation and mechanical ventilation like you described. I think handheld nebulizers, I mean, there have been clinical studies, right, Mel, for decades that have compared the efficacy of nebulizers versus just giving the patient an MDI with a spacer. And as far as I know, unless there's something new that's come along, we haven't been able to demonstrate that the nebulizers are any more effective. They are more dangerous in terms of aerosolizing infectious respiratory secretions. So I think I would try to move away from the use of nebulizers routinely because they're risky. Or if you're going to use them, then the people who deliver them, need to be in full PPE and probably in a airborne isolation space as well. There's kids and adults where, we want to look at the back of their throat and we use a tongue blade and they gag and cough. And I don't think that's a practice that we're going to want to encourage during this pandemic. So I would really think about how much you need to see more as opposed to just having the patient open their mouth as best they can for you and making some treatment decisions that may be perhaps a little bit more empirical than they would be in other times.
This has also come up with intubating patients. Scott Weingart has a great podcast on this. Again, there's a link in our chapter on the ENCRIP podcast about what we like to do right now is lots of high-flow nasal O2 as we're intubating patients. That, too, probably is very good at aerosolizing all of this in somebody who's probably got a high viral load. So probably not the right thing to do, especially since we're not sure that it really improves intubation. That's the kind of thing maybe we should do less of. I'm going to try and read another one here. What do you make of reports coming out of Italy today? We talked a little bit about that. Italy had 200 new cases reported again. Be very cautious about how you read these new cases like this disease is exploding. It's probably mostly just about testing. And I think you're going to see that in the US in the next few weeks. As we get this test, lots of tests are going to be positive and it's going to look like, oh my gosh, everybody's got it. So we have to be very careful about that. But they are reporting a lot of pneumonia, a lot of intubations, and some ECMO cases there. And again, it's hard to get a feel about exactly what's going on. If there are any Italian docs in the ICU or in the emergency departments working and you can hop on the chat, give us your experience, that would be great. We used that a lot during the prior epidemics. There's a question here about EMTLA and the parking lot. So Dave, you ran the emergency department there for decades at Oliveview. Is it okay to triage people in the parking lot in the US when it comes to EMTLA?
I haven't really thought about that. That's a great question. I would, this is a public health advisement, so I think you'll be fine. But whether you, screen and establish that the person is stable or stabilize them, starting in the parking lot or in your standard emergency department, I think you will still be expected to meet that standard. But I think under these circumstances, if you do that in a makeshift respiratory triage screening first, I'm sure you'll be fine.
A lot of people are saying this is going to overwhelm their hospitals, particularly in smaller hospitals. They've got one or no negative isolation rooms. Do you have any advice about what to do under those circumstances? Do you just push the beds as far away from each other as possible? Do you put some people outside in the parking lot? What do you do?
Yeah, no, you put the person who's suspected in a private room, and you use PPE to go in and out. And again, like we emphasize, this is an illness that is transmitted primarily through respiratory droplets, not airborne, not just breathing the regular air. So that's still a very good precaution. We're just extra cautious about this. And influenza, although it is the classic respiratory virus infection transmitted by droplets, it has been shown that there is some airborne spread of influenza and the potential for people to acquire it. So instead of taking chances with this disease that may have 6 times the case fatality rate of flu, the infection control recommendations are very conservative. But just separating someone, closing the door, putting them in a regular private room is quite a bit of protection.
Right. Some other questions then. One specifically, a pregnant ER doc asking, what about pregnancy? I have heard nothing about this. We know that little kids seem to be doing fine. There's no reported deaths as yet under the age of 9. I have no idea in pregnancy. Do you have any word on this?
Yeah, there have been reports in pregnant women, and the fear is that pregnancy is sort of a mild immunocompromising state to allow this half abnormal antigenic chromosomally different person grow in your body. And so we do see some opportunistic infections emerge in pregnancy. We see pathogens that we don't see in normal people, like listeria and things like that. Influenza is more severe in pregnancy and postpartum. So I think there is a concern about coronavirus in pregnancy. However, the good news is that there have been cases of pregnant women who have gotten coronavirus, and they appear to handle the infection well, like young, healthy people would, and not have any more adverse consequences, at least so far from what we learned, because they're pregnant. There also has not been cases observed of vertical transmission of a pregnant patient who's infected to their newborn child. There has been transmission otherwise to very, very young children from the mother, but that did not appear to be vertical transmission. So that's what we know. So far, so good, and good luck on your pregnancy. You might want to not take a cruise
it's probably a good
during
idea.
that last part.
So let's talk about travel then, because a number of big conferences emergency medicine conferences and Facebook and all these other people are stopping their conferences. Semper just a few days ago cancelled their conference. So what do you think about this? One of the arguments is, first of all, you're going to take 1,000 ER docs that have been out working, seeing lots of patients. If there's ever going to be a group of people that's going to have some number of people that have coronavirus, it's going to be an ER conference. Should we be shutting this down right now? What do you think?
Yeah, I mean, I look at it, from the individual who might go to a conference. And I know, Mel, your first question would be, well, who's speaking? Another would be like, well, is this something that I need to do? And if it's not something that you really need to do, then you can look at it two ways. It's a very personal decision. The absolute risk to you is small. I mean, it's small that you'll acquire an infection. If you get an infection, it's small that you won't just, have flu symptoms and it'll be gone. So the absolute risk to an individual like you and me and our colleagues who are listening is tiny. But then, you get to this whole idea of social responsibility. So for every less case there is, then we flatten that epidemic curve. That means we give the systems more time to adapt. We give people who are not infected the opportunity to benefit from drugs that are discovered, or for the population to eventually be protected from vaccine. The less infected people, even if they're healthy and get minor illness, the less vulnerable elderly people will die. So if you don't need to go to that conference, I mean, there's plenty of ways to learn. Maybe not this hour, but other hours, I know there's some valuable educational information that comes across. So you have to decide for yourself. But people, Mel, are going to vote with their feet, and I think you're already starting to see, basketball games where, nobody's in the stands, and that's good, not only for people to protect themselves, but again, for every less healthy person that acquires this, there's less chance that, your grandpa in the nursing home's going to die from coronavirus.
Yeah, I would summarize that the very similar way, which is if you're old, if you've got underlying pulmonary disease, this is not a time to go to the basketball game. This is a time to stay at home and to watch the TV. For the rest of us, we can risk stratify ourselves in that. What's the need for the travel? What's my underlying pathology? And sort of risk stratify in that way. I think a lot of people are confused, like, is the government being overly cautious or under-cautious? And I heard a really good ID doc, and I can't remember his name, but he said, well, just tell me which way you want to get this wrong. If I lock down society and do lots of social isolation and close down everything, I'm going to tank the stock market, I'm going to really affect the community, and I'm going to affect people's ability to make money and do all this stuff, but I can significantly flatten the curve, substantially do that, like they did in China. They took 60 million people and said, you're not going anywhere, and we have the guns to make sure that doesn't happen. So you can do that extreme, or the other extreme is just let it run its course, but if you do that, you'll get this big explosion of cases and you'll overwhelm the healthcare system, and you've got to try and find some balance between those two, and there's no right answer. There's going to be a lot of criticism both ways. You did too much, you didn't do enough, but I thought it made a lot of sense to me. What you're seeing here is just tell me which way to do it wrong. And I think sometimes you'll see it swing from, well, let's just let this see how bad it is, and then when it looks bad, there might be a swing a little bit too much the other way. But that's the problem. You can't do both and all things at once. You just have to decide. There are cause and effect both ways.
Yeah, these are really, really difficult decisions. And even people who would be, you would think, experts in epidemiology, public health, virology, no one knows. We're all learning as we go here. And there's some really critical decisions, like you say. And you can make a mistake by restricting things too much early, which has consequences, real consequences to people. And you can make a mistake of trying to institute controls too late. So these are really difficult decisions.
The other thing that people are asking is when will this stop? I've got travel that I'm going to do 3 months from now. Should I book that or should I cancel it? So we know from flu, we know from the cold season that it is seasonal, that when the temperatures get warm, the virus tends to die, and this is protective. I think we expect that this is going to be a little seasonal, but what do you think?
No.
No?
There's many examples of viral illnesses, including influenza, which aren't seasonal. You guys remember H1N1, swine flu? You know,
2009?
a little bit of deja vu, and hopefully the ending is the same. But, you know, Mel, we were at Olive, we reported the very first case of H1N1 when it came to the United States through California. But remember the first reports, they said 50% of the patients in Mexico City were being hospitalized in the ICU. And then when all was said and done, and remember there was a vaccine and lines for the vaccine, but by then the infection was over. But that influenza pandemic occurred during the summer months. So and then by the end of it, it turned out to have a lower case fatality than usual seasonal flu. You know, we can only hope that, you know, COVID-19 sort of goes that direction, but it doesn't matter, because even with a low case fatality rate, or maybe just case fatality in people who are really old and really sick, if 15% of the world's population gets that infection, then a lot of people die.
So I can't feel better about delaying my travel to the summer because the ultraviolet light's going to kill the bug. You just destroyed my summer.
Yeah, we don't know. You know, I try to stay up and listen to the best experts at predicting these things. I like Mike Osterholm. He's a public health infectious disease guy in Minnesota. So you should try to search him. He's a really good voice. And some people, I don't want to appear too cynical, you know, like CDC folks who I work alongside, and they're awesome. Remember, they're federal employees, so they may not be able to say everything that they feel is true. But I like Mike Osterholm, so if you guys are interested in following a very astute and frank expert as anybody can be, search him. He's very good.
I've got another one. Amish Adaya is from Johns Hopkins. That map that we showed that I check daily is part of the group that put that together. He's trying to sort of dampen down the hysteria a little bit. He's much more worried about the social consequences of people losing their minds over this thing than the virus itself. But he does note that he does think it's going to be about, like as you've said, probably about a 0.6% mortality, which is significantly higher than flu. That in the US alone, that could be 800,000 or more deaths. It's going to be pretty bad. But if we can just do the things that we've been talking about, flatten that curve, spread this over time, develop antivirals, get a vaccine, it's not going to be... This is not the pandemic that we're all worried about, the 50% mortality as infectious as measles pandemic. This is a really bad flu season that's really bad, and we should treat it in that fashion, and that means doing all the things that we're talking about. One specific question that's come up, we've heard about the hand washing. I don't think we need to talk about that. But how long can you wear an N95 mask? If you've got a 12-hour shift, does that thing will last for 12 hours, or should I be replacing it every few hours? Any ideas? I have no idea.
Well, there's a push for consolidating infectious COVID-19 patients. And part of the justification is kind of something you referred to before, which is that the greatest risk of a healthcare worker acquiring it when they are already using PPE is when they take off the equipment, right? And so if you can have a ward or a hospital dedicated to the care of those patients, then those healthcare workers can keep on their PPE the whole time. And I don't know the answer to, what's safest in terms of, changing it out and things like that. But I think the implication is that unless there's a break in the PPE, that you can just keep wearing it.
Yeah, if they get wet or if you tear it, of course, that's not going to be very effective. Look, I think we're having some technical issues with the stream. We have many thousands of people here. Dave, do you want to have any sort of closing thoughts? We will do this again if we feel the need to, as this changes rapidly as we get more information. So this is not one and done. But any closing thoughts for particularly the clinicians out there that I've had at least today, 20 people call me worried about going to work, all the things that they should be doing to reduce their probability of getting infected?
Yeah, okay. So some good news. So there was a group that published their experience from Hong Kong during this first month, where they had 1,200 patients come through the emergency department and into the hospital who were suspected of COVID-19. And of that, they had 43 who were infected. And they followed very much the standard infection control procedures that are recommended, that we've discussed a little bit today. And if you follow those procedures, what they found was no healthcare worker acquired the infection. So that told me the things that we're doing, the things that we're recommending, if you follow them and you're careful and you take your time and you think through when you need to put those on and how carefully you take them off and you wash your hands and do all those things that we're talking about, which is a little bit different than our routine, but absolutely something that everybody can do, then your risk of acquiring the infection is really low. And as we've talked about, even if you get the infection, the risk that you're going to have a bad health outcome, since you're generally, a healthy workforce is also very low. So, I mean, maybe that can quell some of the fear. I think we're at a really special place in time, Mel. Like, will COVID-19, or maybe it already is it the most important disease of this century? I mean, maybe it will be, or maybe this will be like a really good drill to prepare us, for something worse ahead. Maybe we'll learn that higher education doesn't have to be so expensive, or that people can telecommute, or maybe we'll learn how to develop social systems that watch out for the elderly during any type of threat to their health. So, maybe there's a few good things that will come from this. I remember that I was a firsthand witness to the discovery of the most important disease of the last century, which was AIDS, when I was training at UCLA. And, yes, this is a frightening period, and, we're worried for ourselves, and we're worried for the people we take care of, and we're worried for our relatives and friends. But it's also an epic moment, and one that we should all, try to appreciate and learn from.
I think that's a great place to end. I want to thank Professor Talan for spending the time here again. We're not one and done. That was a really hopeful review of what happened in Hong Kong. And I have heard that same thing. This is a good drill. This is serious. This is for real. A lot of people are going to get hurt, but potentially this could be a lot worse. And let's get our systems in place for the next one, because it is inevitable that there will be a next one. Ladies and gentlemen, boys and girls, we'll do another one of these soon if we need to. I'm going to post this so that your friends and colleagues can watch it, and we'll post it as soon as we can after the event finishes. Thanks again, Dave. We'll talk soon.
Thanks,
Be
everybody.
careful out there. Wash your hands. Put your masks on. Herbert out.
Don't touch your nose.
Don't touch my nose, that's for sure.
Only on the screen. I'm touching your nose right now.